So it is now 12:30. I'd like to welcome everyone to the introduction to health equity and community building. This webinar is being brought to you today by the Community Health Training Institute here at Health Resources in Action. We're able to provide you this webinar for free, thankful to the Department of Public Health and their great funding for this project. We wanted to welcome you today to the webinar. Our presenter is going to be Mo Barboza, but before he introduces himself, I wanted to tell you a little bit of how this webinar is going to work. We are going to try to make this webinar as interactive as possible, so there will be times where the presenter will ask you questions, and you will be plugging those different answers to those questions in the chat box on the right-hand side. And so you'll see the little box where you can plug in if you have any questions, especially if you have any issues with audio. Kelly just sent out a chat that says if you can hear us. We want to make sure that you're able to hear us clearly, that you can see the screen, and that you're following along with the presentation. If you have any questions, again, please feel free to type them in your chat box. We will answer them as we move along. And then if you have any questions for the presenter as well during the presentation, again, plug it into the chat box, and we want to make it as interactive and as fun as possible. And so that's going to be helpful on your right. And it looks like this. So you'll see it on the screen. This is what it looks like, and that's where you'll type in all your answers when the presenter is asking questions. And if you have any questions or having any issues as well, this is where you'll plug in your answers. Again, if you have any questions, please let us know, and I'm going to, we're happy to introduce Mo Barboza, who's going to be presenting this webinar. And give us 1 second, we're going to hand over the screen to Mo.
All right, welcome and good afternoon. I'm hoping that folks can hear me. All right. My name is Mo Barboza. I serve as Director of Community Engagement at Health Resources in Action, and wear a few other hats in my community. So I serve also as the chair of the Men of Color Task Force, which is a community coalition. I'm on my local Board of Health and also on the Board of Trustees of a hospital system. So I come at public health and community building from kind of both directions, from the health side as well as the community side, and I've been a community organizer for a long time. I'm hoping that today's session will meet your needs, and as was described to you, there's a space for you to ask questions. I hope that you'll take advantage of that, as well as we'll have a few questions that we ask of you, which are some polls, and sometimes I'll just ask you to make some comment. We want to make this as useful for you as possible, so please include questions when you can, and we'll try to take the ones that seem pertinent in the moment, as well as have some time at the end for as many questions as we can fit in. Without further ado, let's look at our learning objectives. So we're hoping today that once you complete this, you'll be able to describe health equity and diversity in a community context, describe aspects of culturally competent approach to community work, as well as identify strategies for collaborative work when working across differences. We're going to do these both by really diving into health equity and then also looking at some examples from the local context as well as around the country to help us really think about the culturally competent approaches to community work as well as working across difference, and really highlighting the need for that last piece. Today we're going to define health equity. We're going to discuss 4 key questions as just a way to really frame these conversations about health equity. And then again, as I mentioned, through practical steps and examples, really discuss policy change, systems change, and kind of leadership development as 3 really important strategies to addressing health equity. So a few words on language. In the public health world, we've been using language and labels for a long time. Some of you will undoubtedly be familiar with many of these phrases or words, as well as what they've meant in public health. We spent a lot of time in the 80s talking about social justice, and then moving to environmental strategies and really thinking about how do we impact folks broader than just focusing on individual behavior. It led us to really thinking about disparities and what groups, social groups or other groups were suffering different outcomes than others in society, and that led the field to really thinking about what are the social determinants of health, what are the social conditions that are really impacting and affecting people's health. And now we're really thinking and talking about health equity. And what I want to point out is that these are not interchangeable. These aren't new labels on old work. And in fact, as we jump into the definition of health equity, we'll be able to kind of pull apart some of the reasons why working on health equity may be different and than necessarily just focusing on disparities. All of this work has been based on data and being really able to use data and to really think about data in ways that help understand what's going on, and disaggregating data has been one of the most useful tools. This is some old data from our friends in the Southeast Center for Healthy Communities. They had looked at low birth weight by race and ethnicity in their China, and saw some of the differences that low birth weight, how low birth weight showed up in different communities. And if you're looking at this chart, you might notice that there are some places that the Black non-Hispanic community is higher, and some places where the Asian community is higher. And one of the things that working in a culturally competent manner asks you to do is to have a sense of who the folks are that you're working with and where they are and what the contexts are. And so if we looked at this, we might say, wow, you know, the Black non-Hispanic rate in the China towns around Brockton are much higher, and maybe that's a place we should focus, or maybe the Asian community, and that looks like a really high rate. What's going on there, and who are those folks? And then why is it that the Hispanic rate is so high in one place and low in the towns right next to it? One of the things that having some of the local knowledge that I know many of you have in the places where you work is you can look at data and say, there are other factors that are going on that lead us to understand what's going there. So, for example, the low birth weight rate in those towns around Brockton, those are the towns where folks are furthest away from the prenatal care, for example. So that could be one of the reasons why that might be higher there. Or you might look at this and say, who are the Asian communities there, and are these recent immigrants, or is this the traditional and more historic Chinese community, or is this a Vietnamese community, or are there specific cultural groups, and is there a cultural layer that we need to investigate to see why these layers might be a little bit higher in those spaces, and are there things that we may need to investigate further to better understand what those rates really mean. This level of investigation is the precursor to really thinking about health equity, that we have to be able to disaggregate, and we have to be able to look deeply and ask the questions and specifically talk to the people who are suffering the disparity to understand what their reality is. I'm going to use another example just to kind of as a launching pad. Our organization is based in Boston, and we have experience in Boston over the course of the last 20 to 25 years, an amazing amount of economic growth and a pace of growth for the city as a whole, and actually for the region and the state, that is much greater than most of the rest of the country. And if we look at just that, we would think that everyone in Boston is doing pretty well. As this next slide shows, there are some really important things that come out of there. So I'm going to show you this slide in a moment. Developing that health equity lens means that you have to be willing to see it. So as we talked about in that last example, we'd have to dive into those charts to see what's going on with those populations. We have to disaggregate the data and then really have an analysis on race, power, and poverty. And if we have those, then we can see some things that we might be blinded to. So that example about Boston, for for what we were talking about, we looked at household wealth in Boston among selected groups. And the disparity comes to the forefront. So if you look at this chart, you'd say household wealth among white families is near $250,000. Caribbean black and family is about $12,000. And for those of you who don't know, the African American community in Boston has a significant Caribbean percentage, and so that's why this is broken out here. The Puerto Rican families, $3,000, and the African American U.S. black families would be $8. This has a significance both in the disparity that's glaring there, but also that this affects then the health outcomes for the folks who are part of these groups, that there is an effect on the population who fits this profile. And that's where we really want to be able to think about health equity is it's not just that this profile exists, it's not just that folks have different levels of household wealth or income levels or education levels, it's that those differing levels impact the health outcomes that they then suffer. One of the biggest examples that we've seen about the kinds of disparities impacting the outcomes for people in the United States was Hurricane Katrina. This picture is one of the iconic images of that catastrophe where folks were on the roof asking for help, pleading for help while the waters were rising, as you see there written. I'm going to ask you to take a little quiz with me to help us think about what are the reasons that folks in Katrina suffered such different outcomes. So which policy most aggravated the disparity between circumstances of black and white New Orleans? Which policy most aggravated the disparity between the circumstances of black and white New Orleans? Was it A, Plessy versus Ferguson, the separate but equal, B, post-World War II housing policies, or C, levy placement and land constraints? And I believe Gina is going to start the poll for us.
So the poll's open. We'll ask you to go ahead and pick what your answer would be, and we'll give it a second so that we can have a good number of people answer the poll before we close it and show you the results. All right, we'll give it a couple more seconds. Get your answers in there. All right, we're going to close the poll. And there are your results.
All right, wonderful. So I just want to comment really briefly that all three of these are really important policies that had an impact. When they really looked at what were the policies that really defined where the disparities were, it was B, as most folks have on here, the post-World War II housing policies. For those who may be unfamiliar, these were where veterans and their families who received funds could purchase homes and could even build homes, and what areas were open to whom. And the policies basically discriminated against black New Orleans and concentrated poverty in the areas that ended up being worse hit by the storm. These were the areas that had the least access, had the least services, and because of that concentration of poverty, the folks who owned their homes in those areas actually saw their home values go down, and thus added to the disparity that they were experiencing. All of these policies contributed, but that's the one that made the biggest bang. And I think it's a really important one because it forces us to think about what are the places, what are the things that are in place that currently are creating and perpetuating the disparities that we sometimes take for granted, including where people live, what kind of access to services they have, where is it that there are concentrations of poverty or other social groups, and where is it that those groups are not, because that's also the other end of the policies. Those World War II housing policies aligned well with what were already in place in many other areas of the country, redlining, for example, and kept particularly African American families, but other families of color, out of some of the neighborhoods and communities that they wanted to move to, and again concentrated poverty in a few places, and those places then suffered. All right, thank you for taking the poll. We're going to move forward here. So health disparities, differences in incidence and prevalence of health conditions and health status between groups based on race, ethnicity, socioeconomic status, sexual orientation, gender, disability status, geographic location. This list could go on for a very long time, and fortunately we only have the time that's allotted for the webinar, so I don't have to go through all the possibilities, but these are some of the common combinations that we see. And in particular, we really take a look at race, ethnicity as a prime group because it is one of the places where the disparities are the greatest. Some people say, why not focus just on socioeconomic status, or is there a relevance for socioeconomic status when we're looking at race? What we see is that socioeconomic status is often the easier dynamic to look at because there is no place that folks feel like they have to blame for the disparity. They can say poverty exists and so forth, but it's harder to say that racism exists, and that's why it becomes really deeply important that we're able to focus on race and ethnicity when we talk about health disparities, because it also brings up a lot of the other ways in which people are suffering disparities, and it often goes without being mentioned because of the greater difficulty that communities have in addressing some of this. Now, health disparities versus health equity. First, I want to just say up front, there's a false dichotomy. These are not opposite ends of the spectrum or competing interests. In fact, health disparities kind of define the impact of the conditions that health equity is really trying to reduce. So part of what we need to really be able to focus on is where is it that the work that's in place now that's trying to address health disparities is helping to alleviate the suffering, and where is it that health equity can begin to erode at some of the conditions that create those disparities to start with. It's not a new label. So we can't just, some of us used to be the, coordinator of health disparities or the director of health disparities for our department. We don't just relabel it health equity and get a new job doing the same old thing. It really is a focus on the conditions and not just the disparities. And that these are two important fronts. So for the person who's suffering from let's say a chronic disease and the burden of that disease is greater in their community, working on the policy, some of the implications are really important, but they also need healthful living today, and they need the supports that help them live more healthy in the moment, as well as create a better, healthier community in the future. So we want to make sure that both these fronts are being addressed, and that our work doesn't create false dichotomies and put these in competition with one another. Some of you are familiar with these definitions. These are from the Healthy People 2020, that health equity is achieving the highest level of health for all people. It entails folk societal efforts to address avoidable inequalities by equalizing the conditions for health for all groups, especially for those who have experienced socioeconomic disadvantage and historical injustice. I want to just touch on two pieces of those definitions that I think are really important. One is this idea of avoidable inequalities. Many of the ways in which people see the world now and the inequalities that exist, we have to challenge that they do not exist by nature, that these things were caused and created, and because they were caused and created, they can be addressed. and that they can also be avoided, that there are things that we can do to reduce the inequality or get rid of it altogether. And secondly, that we have to really address the socioeconomic disadvantage and the historical injustices, because those two things frame where people are today. So for example, the chart I showed you earlier about the differences in household wealth in Boston, those aren't things that are addressed in the moment, or they aren't things that just happened yesterday. There's a historical context that made those inequalities happen, and it's deeply important that we have both an analysis of what that is and a willingness to challenge it, because there are pieces of what has been told as a story that we're going to have to reframe, both in messaging and how it leads us to solutions. And we'll talk a little bit more about that as we go forward. Our friends at PolicyLink give us a little bit more language. They say that equity means just and fair inclusion, and thus an equitable society is one in which all can participate and prosper. The goals of equity must be to create conditions that allow all to reach their full potential. In short, equity creates a path from hope to change. I like the fair and just inclusion because it isn't enough that you're at the table. It's that you're at the table and able to participate with everyone else equally. And that, I think, is the crux of where we're trying to get to, that your conditions, your background, and other descriptors shouldn't decide how and if you get to participate, but really that you have the opportunity and a real opportunity to be engaged and be at the table. Some of you have seen this chart before, the difference between equality and equity. Sometimes we've used the other chart that's a few folks lined up on a fence. I like this one because it takes the fence away and allows you to really concentrate on the ability of the individuals to reach the outcome that everyone else is able to get to. So on the left is equality, meaning that we are resourcing everyone equally, and we're using here height as a way of thinking about their capacity to reach their the outcome that everyone should be getting to. And the distance there is the challenge. So both that the person furthest to the left has less challenge and they have greater capacity already to get there, and the person in the middle on the left is a little bit more challenged and has a little bit more capacity already, and the person on the right of those three is further. Equity means a distribution of resources, and by here the resources are the boxes underneath, that creates the condition where everyone can reach their best outcome, and here everyone is able to reach the apple. It means that we are redistributing the available resources. And some of you will say, well, there's not, there's more boxes on the right than on the left. It may mean, for example, that if we had to use 3 boxes on the right, we may have to distance everyone a little bit the same or to get them there. We may need to put 2 boxes under the person to the far right and 1 in the person in the middle, or something along those lines. But the idea here is that we are creating conditions where the distribution of resources helps the individuals get to the outcome that everyone else is getting to. So I want to just touch base on this a little bit further, because it has to be that focus on the outcomes, their ability to reach the apple. It has to also be the distribution of resources. And where many communities find difficulty is this conversation about redistribution versus new resources. In public health, we do not see a future in the near future, I'll say it that way, where there are going to be a huge new amount of resources, and that folks will be able to add a whole lot of boxes to kind of try to get to equity. It may mean that we are going to have to redistribute the resources that we have in place to ensure that the folks who are the furthest away from equity and the healthy outcomes have a better chance to get there. And this can be a difficult thing for communities to talk about, and that's one of the reasons why we want to start to build the muscle of talking about health equity and talking about racism and these issues, so that the distance in those conversations is easier to travel. It's often difficult to get to solutions that are equitable when you haven't had the conversation about what the inequity is, or even what the causes of those inequities are. And so being able to see the problem, being able to have an analysis of it, and really being able to engage with folks that are impacted by it in the solution making allows you to have that kind of conversation that brings people in. And I know some of you are thinking about, well, in my community, this will be really difficult. It's difficult in every community. It absolutely is. And whether or not you're dealing with it, or you're working with a community that has lots of resources or not as many resources, or has a history of disadvantage or doesn't have a history of disadvantage, or a community that has a history of advantage, there are certainly opportunities for these conversations to happen, and there's a need in both of those places for those conversations to happen. So I want to make sure that we say that, and we're going to come back to a little bit of that as we go forward. So those were my Apple charts, and I really like them. I just wanted to, again, touch base on the definition so folks could go back and see those. The achieving highest level of health for all people, and really being able to disaggregate the data allows you to see whether or not that's actually happening. One of the ways in which the suffering gets hidden is that we don't disaggregate the data. We don't know what the experience of the minority communities are in our cities or in our towns, and we don't have a sense of what the differences in impact are. I'll use a couple examples to illustrate that. Our friend Jane Ayers at Minnesota Department of Public Health talked about one of their famous examples where they were looking at interventions for radon gas in basements, and so they focused on the homeowners. Well, one of the things that happened when you focus on the homeowners and hadn't really had an analysis on poverty and race and power in that space was that while the radon affected everyone, only 77% of the white folks in the community own houses, as opposed to something like under 20% in the African American community. And so this effort missed a huge part of the community that rented and was equally impacted by the radon gas. Having that kind of analysis about who it is that you're trying to impact and how the intervention either will hit or miss the populations that you're intending is deeply important. And we often run into, these barriers where our interventions don't take into account the conditions of the people who are either adversely affected by the intervention because they're not part of the mainstream, or are equally affected by it but aren't a target of the actual intervention. We'll see a few more of those examples. I want to give you a historic example of working on health equity and why it was important. Our friends in West Harlem, so this is like the high hundreds in Manhattan. As you can see here, this is a basketball court. There's a bunch of housing around it, and that huge smokestack there, this was a plant that the city of New York had decided to put in that neighborhood years and years and years ago. And it goes back now maybe 50 or 60 years where the original decision was made. And this was a treatment plant, so sewer treatment and so forth for the city. And they decided to put it in this neighborhood because this neighborhood did not have political power and had many people of color and immigrants who the folks making decisions at the time thought that they could be allowed to suffer and it wouldn't cause the politicians any harm. And so they made the plans. It took years and years and decades for it to actually be built. Once it was built and the system came on, right away it was above capacity. And because it was, the city of New York expanded by millions of people in the decades after the 50s, the smokestack, instead of running for a number of hours a day, it ran 24 hours. The sewage treatment plant was well over capacity almost all of the time. And what it created in the neighborhood was a really bad air quality. And so people who lived in that neighborhood insulated themselves inside of their homes. And so they put plastic on the windows, they opened and closed the door really quickly, they put towels under the door, at the bottom of the door on really bad days. And when the public health folks in the 70s and 80s started to notice that something was going on there, they saw that there were huge rates of asthma and other associated illnesses in this neighborhood. And at first they tried interventions that were really about treating the asthma and helping people have access to medication and teaching people what asthma was, and did all the wonderful things that we love to do in prevention and in public health. But they realized quickly that that really wasn't changing the problem. The folks were still shut in their homes. This basketball court was previously a park before. It wasn't being used at all. People didn't want to be outside. They would rush to somewhere else, work, school, shopping, and then they would rush home and get inside because the air was so bad. And this is, I want to give folks a sense of how poor this was, how poor the air quality was. It was a kind of a thickness in the air that was choking, as well as oftentimes smelled of, sulfurish and other bad odors and bad smells, and in a way that you wouldn't want to be there, and it would affect your breathing pretty quickly. And folks have been living there for years, obviously, and so over the course of the years had other maladies and illnesses that came up. When they started to really address what the plant was doing, they also saw that the decisions to put it there, to run it over capacity, were specifically done to this neighborhood because the folks in power thought that they could get away with it, and for a long time they did. The organizing that happened was about changing both the plans for that particular installation and that particular plant, and then also the regulations around what was allowable for the air quality around one of those plants. And by changing those policies, they saw the air quality get much better very quickly. As folks would look at this and say, okay, that sounds like a policy change, an environmental strategy. For many, it was also the beginning of really understanding that health equity had to do with not just treating what was going on, but really changing the conditions that caused what was going on. Not just addressing asthma, but changing the conditions that put people at risk for asthma in the first place. For many of us, this is the idea of being able to really go upstream with some of the things that we are working on. And so I wanted to, show you a stream. That's a stream. If you look way in the background, there's a sandbar, and for those of you who like the outdoors, this calm stream probably looks pretty good to you. Sometimes we can't see up around the bend up there, so that's upstream might not be easily visible. That's another metaphor while we're here, as well as that a lot of what's closer to us is this downstream stuff, where we are. And this is what happens to us, is that we see the problem first by what is closest to us. We see people suffering in the moment and see them suffering where they are, and that's what we address. And then when we make some adjustments, we often are adjusting what's directly in front of us. So helping people to heal from what's harmed them, to get better from what they're suffering, and maybe try to avoid some of the things that are harming them where we can. What we don't often do, and this is what health equity is asking us to do, is to really go upstream and try to change the conditions that are causing the disparities that we're seeing. And so I have a few definitions for you. I'll start with downstream. Downstream is really addressing the impact of the results of the inequities. What they saw in Harlem were high rates of asthma among the children and adults who lived in West Harlem, and so the beginning of that process was to really focus on how do we help people with the asthma that they're suffering. Some midstream conditions, or midstream is really addressing the conditions that create or perpetuate the inequity. So when they started to look at the plant itself and make some changes to when it was working, or the capacities and so forth, that was really about trying to mitigate some of what was creating the conditions, or the conditions themselves, so this air quality. Upstream is really removing the conditions that create or perpetuate the inequities, so not just trying to deal with it after it's happened. So you can imagine the difference between planting trees in the neighborhood to try to help clean the air up, and actually turning off the plant or regulating it so that it wasn't releasing the bad air to begin with. And so those regulations, the policies that they sought and got changes on, were the upstream. And so just to, again, to clarify, downstream is dealing with things that are already happening with the impact of the inequities. Midstream is trying to address the conditions after they exist, and upstream is really trying to remove the conditions that perpetuate or create the inequities. So it's another quiz time. I'm going to ask you to take this short quiz with me. I'm trying to advance the slide. Here we go. So is getting a supermarket to open in a community that is designated a food desert, is that upstream, midstream, or downstream? And I think Gina's going to turn on the poll for us.
There it is. So the poll is open. Just like before, I will ask you to choose your answer. And as soon as we get a good number of answers, we'll close the poll. Almost there. Give it a couple more seconds. Come on, you can do it. All right, we're going to close the poll.
All right. Well, it looks like a very few folks chose downstream. Okay, and that's probably right, because we're not just trying to deal with the food desert by just giving people food, for example, or just busing everybody to another place, or opening a farmer's market. Those tend to be downstream strategies, because they are trying to address the impact of having a food desert after it's already happened. And they're also really focused on the impact of that that food desert. The midstream, which is about almost half of folks said midstream, this would be really to try to address the condition, the food desert, in a way that begins to erode at the inequities that it creates. And so the correct answer for this one is that it's a midstream strategy. It really isn't changing the regulations that cause the food desert. That would really be upstream. So if you think about the policies and the systems that create the food desert, that would be upstream. This is almost trying to mitigate the impact of those policies, or mitigate the impact of those policies by putting something else in place so that the conditions don't filter down to the people suffering the inequities. So if you think about this, one way of thinking about it is what kind of supermarket goes there. So for a community that is a food desert, there may be some other factors that are important to think about. So if you put in I'm going to choose not to impugn anyone's reputation, so we'll say a fancy, more expensive supermarket that sells food that is organic and whole, that you may have a difference in the ability of folks to access and use that supermarket even though it's there in the community. So in effect, the supermarket being there would not really address the food desert. Likewise, if the food desert is in a community where folks have lots of resources and are able to transport themselves and have the resources to be able to go 10 miles away and purchase, then they also aren't necessarily suffering from the conditions that the food desert is creating. So it's really important to not only see what's in place, but also be able to see how it's impacting folks, so that when you create the policy change or the change in institutional practice or so forth, that it actually helps impact the people who were suffering to begin with. Very often that's about also engaging the people who are suffering the inequity and having them be part of the addressing of the problem and the solution making, so that solutions really touch the ground. I know some of you might say, well, isn't that really upstream with the supermarket? The difference I would say to you is that the supermarket being in place, or what determines where you can have a supermarket, is a whole lot of policies about zoning, as well as how we attract businesses to certain places. Most of the businesses that are in the places where we like them to be have had some opportunities put in front of them to be there, especially the larger businesses. And you can imagine a supermarket gets wooed very often by communities because they want one to be in their community. That kind of wooing and the ability to have it where people want it is what creates the inequity to begin with. So if we have policies in place that ensure that people have equal access to healthy food in this particular example, then those things end up helping us to make sure that the inequities aren't suffered to begin with. We're going to be using this food desert example in the looking at the 4 questions, and these 4 questions help us to really dig deep into what is going on in a community, and especially when we are focused on health equity, that it helps us to ask some of the hard questions. And so I'm going to ask you to do this with me. We'll first look at the 4 questions. We'll talk a little bit about them, and then we're going to use them to dive into an example. So these are from our friends at PolicyLink. They have really helped push these questions out into the field to make sure that this really gets asked. And I know that some folks may look at this and say, okay, these are kind of provocative, but they're provocative on purpose. Part of this is to maybe ask the questions that can be a little bit uncomfortable, can seem in a way pointed, but also that highlight information that doesn't always get shared and says some of the truths that don't often get said. The point of asking these questions and answering them is to help have a sense of the ground that you're working with, the area that you're really focusing on, and that the answers to all of these questions create opportunities for allyship, for you to find allies in whoever is identified in answering any of these questions. And that's an important piece, that this is not to impugn or to create favor for. It really is to gather information and to really go deep into the spaces where these inequities happen. And so if we're thinking about a specific inequity, and you might be facing a specific inequity in your community, you might see a disparity in who goes to college, for example. A community that I worked with had a very high school graduation rate, but then saw that specific groups within their community had much lower, and in some places almost 50% lower rates of college going and college completion. And they had to ask themselves, what is it that's happening here? What are the other factors that are in place? And how is it that what we've been doing has either contributed to or exacerbated this particular inequity? We're, for today, going to focus on the food desert example that we started with. And so I'm going to show you a chart that we're going to be filling out together. Let's see here. Here's our friend. There we go. I'm going to be asking you to use the chat box to answer this question. So we always are looking at the conditions that exist already. So if there is a food desert, who benefits from there being a food desert in the community? Who benefits from there being a food desert in the community? Please type your answers in the chat box, and we'll be giving you some time to put that in there. Don't be shy.
All right, great. Looks like we got a good number of answers. Would you like me to read some of these off, Mo?
I'm going through them now. Good. I see some good folks there. Yeah, there's some, some ones that maybe will seem a little less obvious. Somebody said maybe hospitals that might benefit. Certainly hospitals would see the after effects of it. And it points out to us it's not that they are actively asking for this benefit. No one is sitting in the hospital saying, I wish there was a food desert so that people would become obese on fast food and have to show up here for chronic diseases and show up in our ER. They're not saying that. I'm sitting at the table and I know that they don't say that exactly. But they might be benefiting anyway. And this is one where, as we mentioned before, that having the conversation with them would really help them to say, oh, wow, this is something that maybe we should think about and that we should look at. I saw in here also people who manufacture cheap foods, as well as those who maybe are some fast food vendors. I'm going to show you a few answers. So local bodegas and convenience stores, they benefit because people go there for their shopping instead of going to a supermarket. Now, it does not make the local bodegas or convenience store owners bad people at all. In fact, they're meeting or trying to meet a need in the community. Very often they're very tied to the community that's there. They're providing a service that's needed. Fast food places, and some folks said like mostly large chains, they absolutely benefit, because if you go into places where there isn't a high availability of fresh, healthy foods in a supermarket that is accessible both location-wise and cost-wise, there are many fast food options, some of them national chains, some of them local, that provide cheap food that isn't necessarily very healthy for you. One that was pointed out to me once was that You know, if you could have one business that you have to give a tax incentive to come in, a supermarket, or you could have many businesses that are all paying you good taxes to be in that community, which one would you choose? Well, many towns and cities have chosen the latter, to have, you know, a string of small stores that sell fast food and other things that give them a bigger tax base than having to fork over a tax benefit to a supermarket. And then another one that came up was the fuel providers, which I thought, okay, well, how does that work? Or gas stations, etc. Well, if you have to go somewhere else to get your fresh foods and go to a supermarket, if you've got to drive 10 miles or you got to take the bus, that's gas in both directions, and there's someone who's benefiting from that as well. Again, this is a long list of who benefits from it. They aren't all causing the food desert. Many of them have no participation in creating the condition, but they are certainly benefiting from it. And this allows you to think about, how do we partner with some of these folks? Who are some folks in here who might be good allies for us? As we mentioned, the hospital might be a really good one because they are interested in population health. The zoning board might be a place where you might be able to have a person or a couple people who really believe in what you're doing. City transit might be a place, even though they're on the other side in terms of they might be benefiting from people taking the bus across town to go to the supermarket. They, you know, if you get on the bus and travel 3 stops, or you get on the bus and travel 18 stops, you got on the bus. They could be happy with a shorter trip as well. So there are ways in which we can, you know, help them to see themselves as benefiting from it as well. So I'm going to ask you to do a hard one for me here. Who is harmed, or who really pays for this food desert? Who is really harmed by the food desert? And again, I'll ask you to answer in the box there. Who is harmed by there being a food desert in the community? And I'll just ask folks to go out on a limb and do more than everyone. Try to be specific about who is harmed. Keep going. Who else is harmed by these conditions? About 1 or 2 more. I'm going to let you all in on a secret that I know who is registered and on board, so I can also tell if you're answering the question or not. And I'll ask you to try to get it in there so I don't have to, you know, thank Susan Jacobs for her answer and not mention Sarah Parks, who also just answered, or Jenna David, or other folks. Thank you so much. I want to notice up front that folks, you know, there are some obvious groups in terms of low income and moderate income residents. There are children for sure who are not able to learn as well, or are challenged to learn if they're hungry or malnourished. Older residents as well, they are definitely harmed by this. But there are some other groups and other ways of thinking about society, parts of society that are harmed. Someone brought in tourism It's a wonderful example. Like if there aren't different and interesting and fresh and new things to eat in that community, there may be fewer folks who are willing to visit it. I know that I go out of my way for, you know, some artisanal something or other that I can't get anywhere else, or let me tell the truth, for barbecue, and that's a place that I'm willing to travel for, and I'll go into the, you know, corners of a neighborhood that don't actually get a whole lot of attention from tourists, but they'll get me because it's food. That's a really good example. Residents have to pay more for fresh produce at a convenience store. If you're even able to get, you know, fresh produce at a convenience store, it's often at a much higher price. That's a really good good example. And I saw a few other folks who mentioned that taxpayers, they're also in a way getting a bad deal because there are other costs to the food desert that are about the productivity of the people who live in it, and some of the things that they also are not able to participate in or not a part of. Let's see some of the bigger answers that came up for folks. So families, the elderly or infirmed, poor people or folks without access to resources, people without transportation, public health, healthcare, and insurance providers. So obviously the health of the broader community population is really burdened by things like obesity and other illnesses that happen in a food desert. Healthcare, many folks who are living in a food desert are not living up to the optimal health outcomes, and that poor nutrition translates into many illnesses that land them in the hospital, and very often are landing them in the emergency room, which is a big cost to healthcare. And insurance providers who then are also being asked to pay for down the line a bit more, but what the costs are to those folks who have been harmed. So I'm going to switch the gears a little bit and think about who leads on this issue. Like, who can really influence folks on this issue, on food deserts? And I'll ask you to think about it in both directions. Like, who really leads in terms of trying to fight against it, and maybe who leads in supporting it and continuing the conditions that are causing it, whether they're doing it on purpose or not. And again, I'll ask you to answer in the box. Give folks a chance to try to answer that again. Who leads? Who can really influence folks on the food desert? Just a couple more seconds there. Let's see if folks can add. I see some really interesting answers here. Community groups, the federal government, activists, advocacy groups, community coalitions, city leaders, the Board of Education or your Board of Health, local governments, really good. The health department, absolutely, local departments and boards of health, zoning boards, absolutely, city planning departments, young people, a lot of community-based groups and coalitions. Someone mentioned the private sector. That's a really good example. You know, they're often tapping into new markets, which is what the person said, and they're also very often more likely to align with what communities want than we give them credit for. Oftentimes they're seen as the people who are acting on community, and they are desperately trying to be a part of community. So we can find ways to include them, and they can be powerful champions for the things that we are working on. So let's look at some bigger group of answers. So city and town government, all those planning boards and boards of elements of government that impact the area that you're trying to work on. Activists of every stripe. So think about your advocates, your community leaders, your community activists, retired people, families that get together, your PTA, all the people who are impacted by this, and all the ways in which a food desert touches the different parts of a community. And you know, some folks might say, well, why would the Parent-Teacher Association take up the food desert as a topic that they would want to talk about? Well, as someone pointed out earlier, the children who come to school malnourished or hungry are suffering in a way that gets in the way of their learning, and that has a direct impact on what the PTA is all about. So you might think about, there are some groups who may not even know or acknowledge right away that this is central to what they are also about, but might find ways, because you bring them into the conversation, to be aligned with you, and they may not be, you know, going to co-lead the effort with you, but they also may be able to share some of their members with you and be able to be on your coalition and support the work that you're doing, and that they have entree with folks that you may not have connection to. So sometimes it's also about gathering some of the people who might be able to help you. On here I put the convenience store lobby. These are folks who lobby on behalf of convenience stores. So one thing to think about is they could be on the other side of this issue. Maybe they don't want a supermarket in the community, or they could be on the side with you. Are there ways in which you could help them to support their local members to be a part of what you're trying to do, and that a convenience store doesn't necessarily have to suffer if there's a supermarket also nearby, that folks will still make local purchases even though they've gone to the supermarket for things, for some other things. And then what could the supermarket also carry? This has been a strategy that many communities have used. It has been to target the local convenience stores and bodegas and try to get fresh foods and practices that help put fresher foods and healthier foods in those places. And I think it's a really important one, and this is a good example of where you can be acting downstream, which that would be to really think about addressing the disparity after it's already in place, while trying to address what creates the disparity in the same place. I want my local bodega to have fresh fruit, because when I stop by for, you know, that, you know, coconut milk for the recipe I'm making, I also want to grab a fresh piece of lemongrass and be able to take that back with me. Or if I'm, you know, stopping by for some onion rings, some Funyuns that some of you I think are familiar with, I may, you know, be swayed by that apple and the banana that's right there at the counter that'll tell me, you know what, maybe I can also have the apple. I'm always about and instead of or. And that also, I want that to be there because I'm still going to show up for the Funyuns, so I want the local to also be impacted. Last but not least is this idea of who decides. And sometimes people think that who decides is about pointing the finger. We want to just lift up that if we understand more of who has power in the decisions, then we have more people who we can help bring onto our cause. And so this may be about figuring out who makes decisions that impact the food desert, whether they know that they are making decisions that are negatively impacting the community or not. So in that box, again, if you want to just focus on who decides in the community around this food desert, who are the decision makers? Let's get a few more folks to answer that one. A few more folks. So we've got a lot of folks who are talking about government and policymakers, zoning boards, local government, the supermarkets themselves, that they also can be swayed to be there. There certainly are supermarkets that have a greater connection to community and communities that they serve, and we saw an example of one in Massachusetts that was in a way pressured by public protest and public support to remain in the communities that they were in and be really tied to what those communities are doing. That supermarket exists today, and every time I go to Demoulas, I think about Market Basket, as some people know it. I think about how many folks in the local communities really stood out and got involved in keeping the stores in the communities that they're in, and making sure that the people who were there knew that they were going to be impacted if they left. And that's a really important way to think about the people as decision makers as well. Large corporations definitely impact that. Supermarkets have a lobby, absolutely, and I'm glad folks put that up there. And the people who do the zoning and those who sell like the land space, and you can think about it also as the people who own a lot of land. So there are institutions that do what's called land banking, and so they basically buy up a lot of property and hold it over the course of decades and then make decisions about what's going to go there based on the value that it has accrued over time. Thank you for answering that question. Let's look at some of the broad answers here. City and town government, zoning board, health board, and I put in here attorney general as just like a general way of thinking about some of the laws and regulations, that it's not always just up to the policy makers, but also the people who enforce those policies to really act to create equity in the spaces that folks are suffering. So this was a food desert. We did a really short version of what you might do in your community with a disparity that you're trying to address. We asked the 4 questions. We thought about lots of ways in which different groups participate, and it's not uncommon that the same group might be in 2 or 3 of these, and maybe even 4. I haven't seen that yet, but besides sometimes local government, in these 4 different spaces, and that tells you also that they are a powerful possible ally. And once you've done this, you'll probably have sheets of flip chart paper with lots of people on there, and you want to think about what are some of the folks that you want to make sure are engaged in your effort. If you're really trying to address the inequity in this particular one with the food desert, who do you want to make sure is deeply involved and engaged? I know looking at this, I think about, how could I get the fast food places to be on board with there being a supermarket? Why would that be good for them? Well, one way, and we see this in many places where supermarkets are part of like a shopping mall, they notice that people will go and buy groceries and then stop at the fast food place to grab dinner for tonight. So even though they're getting healthy food for the next few nights, they might get a cheap or a faster meal for that night. And that's something that, a fast food chain might be willing to say, hey, that sounds like a good idea. We don't want to create enemies. We really want to focus on creating allies, and so finding ways for people to be a part of it, or at least willing to engage with what you're trying to do. I wanted to share one more example that's a little bit more contentious, and that's tobacco. And so this is one that we filled out with a different group in the past. If you look at who benefits, there's a clear set of folks who are often pointed to and get labeled the tobacco industry as the people who benefit from tobacco policies as they are. There are some clear folks who are harmed, and we put up there smokers, even though smokers may be the people who are least likely to champion the kinds of decisions that, or kinds of changes you want to make. They are the people who are also arguably the most harmed. And it's important that we recognize that sometimes the people who are most harmed may not be upfront ready to be part of creating change, but we do need to create avenues for their inclusion, that they need to be a part of this. So one of the really smart things that the folks who work in tobacco did was to upfront say that they are not anti-smoker. They are really working to challenge the tobacco industry, not the smokers themselves. And that allowed people who were smokers to be able to be part of the effort as well. In the who leads, lots of different folks, lots of people, and you see a really broad coalition of folks when when communities are trying to address tobacco. In my community, I live in Cambridge. When we did our tobacco ordinances, there was a broad community group that included something like 24 different people, maybe even more than that. It felt like at times we were talking to everyone, but it meant that we created the kinds of policies that people were really a part of and that they didn't fight against. And so when those ordinances or the suggestions of those went to city council for the kind of approval that we wanted, it was really easy to line up, community members, store owners, advocates, young people, elderly, healthcare folks, line up the whole group of folks to really stand up for the changes that we wanted and we're able to get. So it's, again, really building a strong set of allies and engaging people who maybe don't always have a direct voice in what you're doing, but can be real champions, or at least gateways to the kinds of people that you need to sway. And that's also the, what you look at when you look at who decides, that there are spaces where by creating those allyships, you're creating a better opportunity to really engage the people who decide and to get the decisions that you're looking for. So that was tobacco. That was a really important example because there's lots of success and a lot that we can learn from it, but also that while it's easy to point fingers, it also asks us to really think about how do we engage everyone so that they can be part of the process. I want to look back at these 4 questions and really focus in. The who benefits is usually the question that's hardest for folks to really get their heads around, but once they do, once they see that it really isn't about pointing fingers, but really most of the folks who benefit are not in any way, shape, or form involved in causing the inequity, and when they see that as well, they become more able to be a part of what you're doing and what you're trying to make change in. We want to spend a little bit of time looking at how who is harmed is an important group to really think about. We're going to use an example that really was focusing on health equity and thought differently about the people who are harmed, and that their health equity effort really then took off by thinking about how to engage the folks who are harmed and change the conditions with and for them. Our friends in Multnomah, Oregon, this was their county health department, and Ben Duncan, who's kind of become famous for some of this work, he said that when we talked about disparities, it was simply reflecting the data, again looking at the charts. We weren't telling the whole story. We were talking about the structural pieces. We weren't talking about the structural pieces until we started looking through a lens of race, power, and poverty. we really weren't moving upstream. Now we're focusing on the conditions that lead to the outcomes we see. And that was a real challenge for the work that they were doing because they were so used to, what's wrong, where is it wrong, and how do we fix where it's wrong as opposed to what caused it. And really going upstream is about what causes it and can we do something about that. So what they did was to really bring all the different folks who were involved together they were looking at some of the inequities in health outcomes in their community. They screened something I would recommend to y'all, Unnatural Causes, for some of you who maybe aren't familiar. It really looks at how lots of things deeply impact the health of communities and how those social determinants of health have deep impact and participation in the things that people really experience. They had over 500 people that attended the multiple screenings. They trained people. They used a facilitator guide that you can buy with it to go and do this in small groups and 25 and 50 people at a time and really try to put the information in a place where people could really talk about it and then think about it in their own community. And using this and really developing a equity and power lens led them to really challenge themselves around the services, policies, practices, and procedures of all of the organizations involved, and really the health department put themselves out there to say, you know what, we need to challenge ourselves. And part of that challenge was really to say, okay, they're one of the largest, the healthcare area, as well as the health department, one of the largest employers in the county. How were they perpetuating the conditions that led to the really bad health outcomes for minority populations in their county? What they saw was, you know what, if we created some new partnerships and applied for some new grants, but also really used our contracting power to promote economic development at the local level, we could impact what happens in our county. So for example, simple contracts that many institutions have, like who do you buy your paper goods from, and who does your laundry, and who comes and picks up your recycling. All of these are contract opportunities that you can do at the local level, and what they did was really to focus on, can we contract with local partners, thus building the economic impact of being in the places where we are. So if you can imagine a hospital or a health department and all of the purchasing that they do, increasing the local purchases, making sure that where they use their economic might was improving the economic conditions of the people who they were then trying to impact in terms of health. And that in itself created some of these new partnerships, as well as they looked for other opportunities. That's one way of saying, okay, who's really impacted by this and what's our relationship with those folks? Because what happened with the department, county health department, is that they saw when they did the exercise that the people who were harmed were some of the very people who they are trying to engage, and that they didn't have other engagements with them. They had this really big opportunity in how they contracted to engage them. And so I want to share with you some practical steps. First of all, you've got to gather the data and you got to disaggregate it. So if you know that there is a burgeoning new immigrant community from, Russia or Somalia or Ecuador or Canada in your community, do you have the data about their experience and what they are engaging, not engaging in, where are the spaces that they are a part of the conversation, where they're not? Second, be bold. Have the conversation. You've got to go and have the conversation in the spaces that hold the power, and have the conversation also amongst the people who you're able to impact right away. Have an analysis on race and power and poverty. Be able to call it racism when it's racism. Be able to say that communities have different levels of power and that it's not fairly shared, and that poverty, while by itself doesn't create disparity, it can exacerbate some of the disparities that people facing when the opportunities aren't shared across the economic spectrum and the resources to get people to the optimal health outcomes aren't equitably distributed. We have to examine the existing disparities. We have to say what's going on now, and then look upstream and say what are the conditions that cause these disparities? What are the policies and system practices and institutional practices that continue these inequities, exacerbate these inequities, and maybe even cause them? Answer those 4 key questions that we talked about: who benefits, who's harmed, who leads, who decides, and then target a specific change. It's not okay to be overwhelmed by the answers. All right, we've got to decide what we want to do and get after it. Find the allies and the points of leverage. Find the places where people are willing to get engaged. Plan and act. Plan and act. Get engaged with folks and then take some action. These small actions will also lead you to some of the bigger actions that you want to get to. So you want to start the ball rolling. I want to make sure that I cover a couple of the other steps, and then we will open up for some questions. So under who leads, one of the examples was that we're going to share is about when you notice who's missing after you've answered who leads, then you're also responsible for doing something about it. So cross-sector collaboration, do we have all the different kinds of folks who can impact us involved? Are the usual and unusual partners part of it? In Cambridge, where I live, one of the things that made me really understand how different some other communities were dealing with things was that it wasn't ever a question that at a community meeting there would be people from the police and public works and from local business and from the hospital system, from human services, that whatever the topic of the community meeting, whether it was directly affecting them or not, that they were part of the community. They were part of what was going on there. And that you would have some of the unusual partners, some of the business folks, and maybe some of the people from the clergy, and maybe some of the folks from the student body at the local colleges and universities, that you would have some folks who don't have a direct connection, but because they're involved in this collaboration, the next time you're engaged with them, you already know how to work with each other. And you build this muscle of collaboration that deeply impacts your ability to take on challenges in your community. And part of that is making sure that you are inviting to the table in real ways the usual and unusual partners. The piece that I want to make sure that we really target is that we have to include the voice and the participation of the affected group of people. We have to make sure that they are positioned to be part of the decision making as well as involved in the beginning when you're starting to identify what the solutions are. Our friends in Worcester gave a really good example of this in their community health improvement plan. They decided that part of what they would do to impact the racism that was happening in their community and some of the institutional racism that led to the inequities that they saw was they had to increase the participation of the people who were really being preyed upon by those policies and the history of disadvantage. And so they included an effort to recruit and organize a cohort of 100 grassroots leaders, including 25 young people, to build up their skills so that they could participate in the conversations and the processes that were about changing public health in Worcester. And that was a really powerful step to make sure that you engage the people who are suffering and who are part of the target group. And you want to do that as early as possible. When we talk about those practical steps, get them involved in when you're starting to look at the data. Ask them if the data that they're seeing makes sense. And when you disaggregate the data, ask them why they think it is what it is. That's part of us really ensuring that our process is really competent. Last piece about who decides, we've got to really deeply engage the folks who are part of this effort and help them to build closer connections to the people who make the decisions. So we want to recruit them, we want to engage them, deeply include, but we really have to get to this idea of empowering, that their decisions matter also and matter with the ones that we're making, and that they are seen and are visible and are part of what happens when we address the people who make the decisions about the inequities that we're seeing. When we're trying to make policy change, they've got to be at the table also, and they need to be part of what we do with the solutions. With that, I know we're getting short on time. I want to open it up to some questions. You can use the question box again to ask some questions, and we'll try to take a few before the end of our time together. Any questions at all? Okay. Well, I want to thank folks for your time, and thank you for being engaged. We got a couple things we want to share with you before you go, so hold on.
All right, thank you, Mo, so much. We want to thank everyone for being a part of this webinar. And we want to let you know that this webinar is a part of a series. So we have our health equity series coming up. Registration should be opening soon, and Mo will be leading us in most, if not all, of these trainings, hopefully with some help from other presenters. But we're excited about it, and so please stay on the lookout. I know that a lot of you hear about our webinars and trainings through our newsletters, and so we'll be sending out more of that information once registration opens, and we hope that you are a part of these trainings that we have coming up, along with our CHIP series, which is also starting this month, and that's also a series that's happening over the course of the next few months. So we're excited about all these great things that we have going on, and we hope people stay engaged. Please feel free to visit our website, hriainstitute.org, if you want to get some more information to register. We will send out all the slides and resources that Mo mentioned in his presentation today, along with any other resources. And if you have any additional questions that seem to come to your mind, we will send those off to Mo and sort of get people the information that they're looking for. And as you close out this webinar, please feel free. We would love for you to answer our survey that happens at the end of this webinar so that we can get some more feedback and get some more information about what it is that you want and what we can offer the community in terms of training and all the things that we have going on. But if we don't have any other questions, I think we're good to go. I want to thank Mo and thank everybody, and we'll see you at the next webinar and or training.